Welcome to Catholic Ethics and the Challenge of COVID-19, a live webcast series presented by the Catholic Health Association and Georgetown University in cooperation with the Pellegrino Center for Clinical Bioethics. Thank you for joining us. My name is Ronnie, and I'll be the operator for today's event. Before we get started, I'd like to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. There will be a question and answer portion of the webinar. To submit a question, please click on the Q&A icon located at the bottom toolbar of the Zoom platform and enter your question. Please note that today's presentation is being recorded and you'll be emailed the recording. We are joined today by Brian Kane, Senior Director, Ethics for the Catholic Health Association. At this time, I'd like to turn the presentation over to Brian for opening remarks. Brian, the floor is yours.
Thank you, Ronnie. I appreciate that. Good day, and thank you everybody for joining us for part 3 of this special series presented by the Catholic Health Association and Georgetown University entitled Catholic Ethics and the Challenge of COVID-19. As we begin our discussions today, I'd like to begin with a short reflection and prayer that we can enter into the presence of God and that we can join together as a community. Loving God, Holy One, your desire is for our wholeness and well-being. We hold in tenderness and prayer the collective suffering of our world at this time. We grieve precious lives lost and our neighbors standing before an uncertain future. We pray, may love, not fear, go viral. Inspire our leaders to discern and choose wisely, aligned with the common good. Help us to practice social distancing and reveal to us new and creative ways to come together in spirit and in solidarity. Call us to profound trust in your faithful presence. You, the God who does not abandon. You, the Holy One, breathing within us, breathing among us, breathing around us in our beautiful yet wounded world. Amen. We're very pleased today to be joined by 3 panelists from Georgetown University who will focus upon the topic of organizational ethics for the first 30 minutes and ethical issues in labor and delivery in the second 30-minute section. So to begin, Dr. Alan Roberts, who practices critical care medicine at Georgetown University Hospital, where he serves as the Associate Medical Director for the hospital, as well as the chair of the Clinical Ethics Committee. He's also a professor of clinical medicine at Georgetown University Medical Center. Also joining us today is Dr. Sarah Vitone, who is a clinical bioethicist with the Pellegrino Center for Clinical Bioethics and an assistant professor at Georgetown School of Nursing. She also serves in clinical nursing administration at Suburban Hospital, Johns Hopkins Medicine in Bethesda, Maryland. And rounding out our panel for the second 30-minute section is Dr. Siva Subramanian, who teaches about pediatrics, neonatology, religious traditions in healthcare, and complementary and alternative medicine at Georgetown University Medical Center, who also serves as chief of the neonatal intensive care unit. Welcome to you all. In the first section, Dr. Vitone and Dr. Roberts will discuss the COVID-19 response to crisis standards and resource allocation. And so with that, I turn it over now to Drs. Robert and Vitone to begin their discussion. Thank you.
Thank you, Brian. This was a very kind welcome, and we are pleased to be here today. This is an unprecedented time for all of us. Healthcare organizations are at the forefront, working with clinicians and public health and governments to respond to keep us from crisis. From an organizational perspective, we try to stay out of crisis and maintain our ethical integrity.
Yes, and as I was thinking about this presentation, I always like to share from my favorite cinema, and the movie Sully. If you haven't seen it, you should leave this conference after 2 o'clock and go right to Netflix and rent Sully. Of course, this is the Hollywood adaptation of the flight that came out of New York City and had to land emergently in the Hudson River. Organizational ethics, I believe, are encapsulated in the person of Sully Sullenberger in this movie, where he went from a business as usual model to a contingency to a crisis model on very short order, and delivered safely both his staff and, if you will, his patients, the passengers on the airplane. Very few people had very minor injuries.
Yeah, that's a great analogy, Alan. Organizational ethics is the application of an ethical framework to a system of care, including its structure, policies, and practices. Organizations intentionally use of values, guide the decisions of the system to plan and respond. Organizations respond to both internal and external stakeholders, and those organizations that focus on ethics have high respect for their employees and their communities. Organizations communicate their commitment to ethical decision-making through its mission statements and its organizational code of ethics.
Yep. Now, here at Georgetown University Hospital, MedStar Georgetown University Hospital, you know, our thing is to provide for the physical and spiritual care and comfort to our patients in the spirit of what we call cura personalis, care for the entire person, the holistic care of the person. This mission statement communicates the purpose of our work, and it embraces not just our patients, but also the people who care for the patients. Now, we want here in our organization to create a culture that fosters clinical sound ethics, practice, and decision-making. And organizations have to act with integrity in order to do this. Organizations, just as individuals, serve as moral agents in this important endeavor. Integrity is supported through leadership, values, integrity of mission. We have to have a culture where it is safe to disagree. My sort of mantra is that dissent is not disloyalty. Rather, dissent can be the greatest form of loyalty to an organization. And an organization needs to take in all sides of the issue, value all input, and filter it together, but also be able to make the hard decisions. Organizational integrity, like personal integrity, is when you factor in all the competing issues and make a decision which cares for both customer or patient as well as staff.
One of the important parts of today's conversation is to also consider what and how Catholic identity is valued in the Catholic organizations. And at the core, this identity is inspired by Christian values, including respect for dignity, providing holistic care, promoting justice in the workplace, looking at the needs of the poor, contributing to the common good, and importantly, financial stewardship is seen as one of the more important identities in Catholic healthcare organizations. The ethical and religious directives provide guidance here, and Catholic institutions are challenged to develop leaders that embrace these teachings, the Catholic teachings and social values, promote organizational culture that is sensitive to spiritual needs, and to also integrate the mission into the clinical and professionals in the organization.
So Sarah, you know, to that point, you know, one of the things that strikes me about this hospital also is that there's sort of a bidirectional relationship with our non-Catholic participants. For example, we're a Catholic hospital, but not everybody who works here is Catholic. And so how do we maintain the respect for every individual? How do we maintain respect for the diversity that we have while maintaining the context of the Catholic background and identity? You know, in the same way, going the other direction, we work for a secular organization. And so how do we then maintain our Catholic principles against the backdrop of the secular world we live in? It's a challenge both ways, but this is a great thing about the Catholic tradition. We can do this.
Right. Agree. And our organizations also use ethical principles that are common in our everyday work.
Yeah. And I just, you know, for example, you can take medical ethical principles, and we have 4 of them generally, and I'll concentrate on 2 of them here. That beneficence is on the part of the physician or on the part of the hospital or the healthcare organization has to do with doing right, doing good, making the right clinical decisions. And of course, the corollary of that is non-maleficence. We want to do everything we can to prevent harm that may occur. Now, of course, this beneficence is held in balance with the individual's autonomy, whether it's a patient or an employee or associate. And it's that balance between the beneficence of the organization and the autonomy of the individual players in the organization that promotes finally the just and equitable distribution of policy and resource.
Mm-hmm. And I'll just add to that, there are some additional principles that we've been thinking about in the time of the pandemic that are important to just note. The idea around solidarity, a respect for the common good, the working together of the organization with their stakeholders, and then participation in that. How are stakeholders, how are our employees, how are our administrators involved in developing and implementing criteria around the process and policies, and what voices should be at the table. In addition to that, we've already sort of mentioned about stewardship, that the use of resources has to be attentive to maximize effects, minimizing risks, and efficiency is of course paired in there. And reciprocity, how the organizations and their employees work together in kind to move the mission forward. And
yeah, and Sarah, just one comment there. You know, you and I were talking about this just a little while ago, that one of the things that is sort of lost on many people, including myself, was the meticulousness to which we have to be, and which Catholic organizations are very careful stewards of financial resources. And we're going to talk about this going forward.
Yeah. So moving forward, I think it's important to remember that one of the more fundamental premises that we have at the time of the pandemic is that ethics continues to guide us in our decisions and our actions. That ethics is required more, not less, in dire circumstances, and provides the necessary framework in these novel circumstances.
Now, I just want to touch very briefly on the unique aspects of COVID-19. Now, we're going to deal with COVID-19 in general, as we would and should with any other disease. This is just the latest thing to come our way, and we're going to latch on to the specific nature of the disease as we take care of these patients and our colleagues. It's extremely contagious, this disease, and there are extremes of clinical manifestations. Up to 25% of patients may be asymptomatic carriers, and it runs all the way, the spectrum, all the way to patients who come in with respiratory failure and then multi-system organ failure. There's an extremely high mortality rate in patients who are greater than 65 years old and who wind up on the ventilator. Death can occur at any age. And after an initial period of improvement, we've seen both in Seattle and China and here, that sudden death can occur even after it looks like they may be getting a little bit better. Minorities, like in so many cases in medicine, are afflicted in greater proportion than non-minorities.
Okay. So one of the things I think we've been trying to do all along, right, is to maintain that contingency stage.
That's right. And you know, as we look at the sort of the progression to from one stage to the other, and this is just a nice graphic. I'm not going to go through this very busy slide word for word, but just to give you an idea of how we in medicine and how we as organizations and hospital systems think about progression. In the green, you've got the conventional sort of business as usual. This is Sully when he's coming off the ground, the airplane's working, the geese haven't hit it yet. And then, you know, as we shift into contingency, this is the time when looks like resources are going to be scarce, but they're not scarce yet. When the ventilators are perhaps being used up, but not used up yet. In the far right is the orange. This is when this is the crisis situation. And the organizational integrity, the ethical burden, if you will, of organizations is to maintain the status quo, the steady state, in the contingency phase as long as is possible. How do you do this? Well, for example, in the case of ventilators, you get creative. You work with your technical team to figure out if you can ventilate 2 patients or more on one ventilator. You bring in the veterinary ventilators. You train up hospitalists to work as intensive care doctors. This is the training phase, and we're sort of in this at Georgetown now, where we haven't had to shift into crisis mode yet, but we are prepared for it because we're training up the people we need to train. We're thinking creatively about how to optimize the assets that we do have.
Can I just come in here for a second and just when we're looking at these different ways of contingency stage and conventional stage and crisis stage, how do we know when we're actually in a crisis stage? Who makes that decision?
Okay, well that's a great question, and I think every entity has responsibility to itself, to its leadership, et cetera, to know what is the algorithm and where these decisions get made. Now, for example, in any given jurisdiction, it is up to really the local jurisdiction. In DC, that would be the city government, the mayor. In Maryland or Virginia, it would be at the governor's level to declare when this happens. And the reason for that is that to have the decisions made at a higher level than an individual hospital or individual provider actually unburdens the individual hospital, the individual provider. Protocols may be instituted that are set up also at the higher level, and then these are maybe tailored to the individual hospital, and this becomes important in a Catholic hospital specifically. Dr. Donovan and I spoke to this a couple of weeks ago on this dialogue.
All right.
So the decisions were made at a higher level, yeah.
Thank you.
All right. So one of the things that's unique to organizations is that they do have duties. And so we have to think about the idea around duty to care, organizations' duty to plan and safeguard and to guide. And there was a great article in the Hastings Center recently that I refer you to that walks through quite a bit of this. But I just want to make sure that we hit the highlights here on our obligations to patients. We have an obligation to care. Organizations have to plan and have procedures and policies in place. And we think about how we do have these emergency protocols that hospitals will go to provide continuity. We're in kind of an interesting situation where a blizzard or a hurricane and those kind of policies that you have in place are relatively short term. We are in a situation to be using those kind of policies for months and maybe even much, much longer. We have to think about the families of the patients, our obligations to continue to connect to them because we have been limiting visitors into the hospitals, and we have to make sure that we are maintaining the individualized care for the patients, helping them have agency to make decisions. We have to be sensitive to the vulnerable, and we're starting now to think about the unaddressed needs of patients who've been waiting out in the wings.
And Sarah, I'll add to that there's a lot of needs, and I think that go sort of invisible. There's the visible needs, and then there's a lot of invisible needs. We have to be sensitive to the stressors on our associates in the organization that we don't necessarily see. And I think you're going to talk about that on this next slide.
Yeah, so we start to think about how we're working with all of our healthcare workers, and we have to embrace the idea that it's not just the nurses and the doctors, that we are thinking about the entirety of the organization that is required to make the organization run. So we're thinking about the folks in the kitchen, the folks that are helping us in environmental services. How are we feeling about the various administrators, the social workers, the various people that are making the organization run and helping us to take care of these very sick patients who are with us. And we have to think about these people because these are the people that run into the fire. These are the people who are out on a limb for us, and we have to make sure that these people who are ready to take the challenge are the ones that we are protecting. The organization will certainly not be able to be successful if our staff, if our healthcare workers are not with us. And so that kind of protection is really very important. We have to think about also addressing not only those things, but also how are we helping their families? How are we making sure that the healthcare workers' families are also protected during this time? And what organizations are doing some really marvelous things out there to make sure those continue. The communication that we can do as an organization to decrease the anxiety level, the uncertainty level of the staff can really be important to helping dissuade any distress that they're having in their own workplace. And it's highly important to these essential employees.
Yeah, I agree. You know, Sarah, you may have been like me, the recipient of about 1,000 emails per day, many of which have to do with COVID and what we're doing here. Well, you know, I can't read 1,000 emails a day. And so consequently, in terms of communication, again, it has to be calm, measured, appropriate to the level of the situation, but also there needs to be in an organization, a communication sort of clearinghouse. Anything you want to put out there needs to go into a bin. It needs to be paced and put out periodically, maybe once or twice a week, updates as needed, but also have a way in terms of reciprocity for individuals to raise questions which will get heard and answered offline. Very fundamentally important. More and more to the point, every associate, whether they're a doctor, a nurse, or a custodial engineer, or a security guard, needs to be publicly equally valued in the eyes of the whole organization.
Yes, I completely agree. The third point that we wanted to make today was around stewardship of resources, and this sort of combines into the first two. But coordinating with local and state and federal agencies have become even more important during this pandemic.
That's right. And anybody who watches the news is somehow perhaps struck with with what seems to be sort of a discordant response. What's happening at the Fed, what's happening at the state and local levels. Well, organizational integrity, again, the ethical burden is to maintain their ownership of their piece of it. It's going to be like, you know, important not to hoard where you have a bunch of stuff that you know you're not going to use, but rather you stockpile what you think you're going to need. And of course, the biblical precedent is Joseph in the land of Egypt and stockpiling what they needed for the coming famine. You need to have good stewardship of personal protective equipment, maintenance of it, and safe maintenance of it so it doesn't deteriorate. Same for beds, medication, staff, and the testing capabilities. So to the extent that one can, in the thick of this crisis, begin to proactively think how they're going to steward their resources. And we would rather call it stewardship than reallocation. Stewardship does involve stockpiling and planning ahead.
Right. One of the things that we saw, I thought, pretty early on was a lot of coordination between various organizations in our region who could share PPE, who could donate gloves and various things to different places that needed it, because we had different needs in different parts of the city. And so that's one of the things, that having those good coordinations in your region is important to do. One of the last points that we wanted to make is to talk a little bit about fiscal and policy obligations. Organizations need to stay afloat. We need to continue to be able to provide service. So transparency, again, can't say that enough, is important. Using your ethics services. So ethics consult services being brought into things early on to look at policy, to be thinking about how we're driving forward. Ongoing systematic review, so that on a daily or weekly basis, the organization, the administration, the leaders, and the clinical teams are continuing to think about moving forward. This is where the planning, the mitigation continues on a very routine basis. And then we talked a little bit about that comprehensive after action, the debriefing. How do you get back to normal? And that's so much a part of what organizations are going to be doing.
And you know, it's not too early to do that. This has to be a comprehensive, detailed, granular after action that once this crisis is over and even before it's over, we start to think for the next 6 months, what did we learn and what do we need to tweak it so we can do it better next time?
Absolutely. So I think we have to at least address the idea of what happens when crisis, if it does come.
Yep. So when the crisis comes, I want you to just think about Sullenberger. The crisis standards, for example, we're going to treat COVID like any other disease, but we're going to maintain throughout the whole thing our ethical principles of beneficence, autonomy. Nothing changes, just like when Sully was landing the plane, the physics of the plane got him down with his good sense. Nothing changed because of the nature of the crisis. You apply principles. You collaborate, you avoid alarmism, you speak calmly to your people, and then you begin, as you move from conventional into contingency planning, how are you going to ramp up how are you going to adjust what you have, adjust what you're using, get creative, and then, you know, collaborate between the clinical side, the administrative side, bring in your ethics consultants, and using the ethical principles that you have, you move gently from conventional into contingent planning. And then, if necessary, you're actually prepared when crisis hits.
So, Brian, we've come to the end of our prepared comments. If there's any Q&A, I think Alan and I are prepared. So
Okay, I think we're going to have time for maybe two to three questions. So we're getting very close to our half hour. But we're talking before about these crisis levels of care and implementing certain standards of care. And Dr. Roberts, you mentioned that those decisions are made at a higher level for those kinds of decisions. And I'm just wondering if you could speak to the question of what does leadership really look like on an organizational level, you know, as we move between those stages, particularly contingency to crisis. You know, what should leadership look like in terms of how individual health systems or hospitals make those decisions in conjunction with clinicians on the floor?
Sure. Well, thank you very much. I think that the most important thing is to maintain your sense of identity as to who we are as an organization. And for example, if we get, if the local jurisdiction pushes the button and says, okay, we are now in contingency moving into crisis mode, then our identity as a Catholic institution is going to guide how we embrace the provisions that they've made. For example, to go back to Dr. Donovan's and my comments a couple of weeks ago, if ventilators become scarce, well, we have to think through the allocation and reallocation of those through the lens of the ERDs and the protection of the most vulnerable, while also attempting to maximize benefit for the most. I think the maintenance of our Catholic identity is key to how we navigate this going forward. Difficult decisions, to be sure, but again, we can do this.
I would just add that, Brian, I think that should we get to those points, we would be using some administrative support, what we might call triage teams to help the clinicians, because it will be quite an out of ordinary experience that the clinical folks will be working under, and we want to provide as much support there. We want to keep the aspects of moral distress or moral injury as mitigated as possible, but this will be completely untested times for the clinical staff.
Right, and so I mean, just to follow up, and what you're basically saying is the structure has to be there to begin with before we get to these levels of crisis. Otherwise, we can't be making them up as we go along. We're really implementing, you know, a vision and a mission that's already present in terms of the work that we do. Mm-hmm. Thank you very much. I appreciate your time today. And on the last topic of moral distress, we will be addressing that topic next week on May 7th. So, and like you'll be back with us, and so we'll explore that a little bit more detail next week.
All right. Thank you very much.
Thank you. So we're going to move to our second presentation now. with Dr. Siva Subramanian. Again, he teaches about pediatrics and neonatology, and he is the chief of the neonatal intensive care unit at Georgetown University Medical Center. So welcome. I think you're on mute still.
All right, I just want to get back to the first slide that I'm trying to, having some, I'm not able to get to the first slide, I'm sorry.
If you just hit the left arrow, that'll work.
Yeah, I don't see a left arrow, that's my problem.
On your keyboard?
Yeah, I don't see it.
Maybe try clicking on the slide and then doing the left arrow.
Yeah.
There we go. Good.
Sorry about that.
Well,
These are all
again.
the challenges, the technical things of the new ways of teaching, you know.
Yes, yes.
You know, we are now moving from a great presentation by Sarah and Alan on the organizational ethics to more particular effect area in the clinical medicine. And even in that, we are going to narrow down to talk about what is this COVID-19 in terms of pregnancy, neonates, and children. And I just want to have the context established first, the medical context, before we touch on the ethical aspects and open it up for questions. The data from China, Italy, and USA so far suggests the pediatric coronavirus 2019 cases might be less severe than in cases in adults, and the children might experience different symptoms than adults. So that's one. Whereas in pregnancy, they seem to have similar symptoms like adults. In the preliminary descriptions of the pediatric COVID-19 diseases, relatively few children with COVID-19 are hospitalized. And this is a blessing in a way. The pediatric patients might not have the typical fever, cough, and some of them may actually have GI symptoms, diarrhea, and lack of taste and smell. And so far, severe outcomes have been very rarely reported in children, even though there has been a case here and there. One-year-old child has passed away, teenagers have passed away, but they're usually who have had some other complications and not the usual. The patients with less serious illness and those without symptoms likely play an important role in the disease transmission. This is where we need to be careful, because the children don't have the typical symptoms, the typical problems of the adults. It may be missed, and they may play the carriers. That's why closing down the schools and colleges was predominantly for that purpose, because the symptoms are not typical, but they may be carrying. And so they may have a major role in terms of transition. As well as in the infants, particularly the less than a year, the fecal oral transmission also should be, the caretaker should be aware of. And I probably will skip this slide just to give you the same information. You know, how many neonates have been sick? Not much compared to the children as well. But 80 to 90% are asymptomatic. And so a very small number, 10 to 20% have any symptoms of whatsoever. There is also the question of COVID positive mothers who are coming to deliver. What are the neonatal outcomes of these babies? It just so happens the COVID positive mothers during pregnancy do not necessarily have any worse off disease than other adults. Normally you would expect in viral and bacterial diseases during pregnancy, because there is some reduction in immunogenicity of the pregnant woman, But so happens so far, it has not been different. And in fact, most of the cases during pregnancy also has been mild to moderate and much less in terms of serious. And there is no major evidence to clearly link the babies that are born to the mothers who are COVID positive are infected at the time of the delivery. And even if there is one or few positive babies, neonates who had a COVID positive test, are usually asymptomatic. And if any symptoms are there, and it is usually attributable to concomitant conditions such as prematurity or infection in babies than the COVID-19 itself. Is COVID-19 a problem during pregnancy or delivery? To date, we don't think there is a major effect that has been shown in utero when the pregnant woman gets an early infection early in the pregnancy. Unlike other infections, we have not seen any congenital malformations or early increased in utero death so far. As we collect more data, it may become more apparent later on, but right now it doesn't seem to have an effect on the fetus. And there is also no confirmed maternal neonatal vertical transmission so far. This is a point, I'll come back to that later. So far, it doesn't seem to pass through the mother to the baby, even though there is a very recent case from Peru that has been published that there may be in a neonate early test that is being positive within the several hours after cesarean section delivery. But we still have to investigate that further. And all the samples in the amniotic fluid or the breast milk has not shown the virus at all. And the other question is, will it hurt the baby? Again, as I said, it doesn't seem to cause any problems so far. The only thing that has been shown in China, a percentage of mothers, it looks like are delivering prematurely. But about 10% of the normal babies also, normal pregnancy also end up in premature delivery. We haven't seen that significant increase in that, but we just have to follow that data. Currently, the summary of the current treatment options, no definitive treatments available to pregnant women who is seriously ill or to the children, except the news that you all would have heard. This is one of the things I had to update this morning, is remdesivir is an antiviral medication that seems to have, in the early part of a controlled clinical trial run by NIH at the University of North Dakota, the early results show that it is safe and it may have some efficacy in reducing the number of days of hospitalization and may also show reduction in mortality about 27%, even though that did not reach statistical limits given the number of people enrolled. But this gives a promising look in terms of potential treatment and thereby containing and mitigating the disease. Several other reports, anecdotal reports, have come with very many other treatments that have not shown yet to be clinically proven. The one other fact that I just want to mention, Justin, is the vaccine news that you would have heard from Oxford Institute. They seem to have modified a vaccine that they have been working on for MERS, which is a previous COVID infection that happened from Middle East, and that they are able to address that content, which has been shown to be safe, that vaccine. And now they are moving further into clinical trial with 6,000 people. And so they feel if this works out well with this coronavirus, by December, January, they might be able to come with a vaccine. Very promising. And of course, there are no human studies on disinfectants and probably harmful or light therapy so far. Let's come to, after setting the stage with the medical component, the ethical issues in pregnancy and children, and quickly review some ethical principles that are generally applied in clinical situations. In fact, Alan referred to that also. I will be repeating that. Some of that specific situations, pregnancy, newborn, and children we will address. And the last part that I want to address is the allocation issue in extremely low birth weight infants. And this is something that is important as it is coming up. These basic premises, Dr. Dan Sulmasi presented to CHA earlier last week, and this is from his as well as the ethical principles of basic premises. Sarah also mentioned it. Circumstances do not change the ethical principles. Applying ethical principles to whatever circumstances that one encounters, and whether it is pandemic COVID or standard serious illnesses. So with extraordinary circumstances like this, one needs the ethical principles even more so than before. And this is the basic principles. You know, we are from Georgetown University, and where the principles of bioethics were articulated by Beecham and Childress many years ago. And the principle of beneficence and non-maleficence that Alan alluded to, and what is in the best interest of the patient and not do any harm, and as well as balance that with the principle of autonomy, you know, respect to the patient as a person and as a moral agent. And then the principle of justice, you know, apply this, you know, equity and fairness should exist in applying this principle of justice. Even though it is important during these critical times as a solidarity we live with, and, you know, the give and take and help each other and as a community, you know, is an important principle, but you have to be in consideration to all the other principles as well. And I want to add, you know, some of these values that we have in terms of specific principles, you know, the virtues that are very specific to medicine. And you would recognize, obviously, the healthcare workers needs to have the competence and needs to have the altruism. You know, Dr. Pellegrino is very, very focused, was in terms of what he said, in terms of that as medical providers and nursing providers, we should be looking at those who are vulnerable and ill than self, you know, and the fidelity to trust, obviously, and compassion that we have to exhibit. And every frontline healthcare worker, as I mentioned, not alone just the doctors and nurses, everyone who comes to the hospital, every public health person, and including the frontline police and fire also, you know, are working. You know, we have to show compassion to the patients, families, and as well as all the others who work tirelessly. You know, we got to have some humility, you know, when we are doing that, we are doing it with God's blessing and as an instrument. And so that is very important. And most important is that we need to maintain our integrity, you know, in terms of whatever that comes up, how we apply that to the patients. I just want to mention a few issues that are specific to our pregnancy and children, and some of the issues that have cropped up with COVID-19. These are issues, and I will take a couple of them at a time and elaborate on it. Separation of COVID-19 positive or PUI mom and the significant other, you know, the husband during the delivery. And this is a issue. And the separation of mom and the baby after delivery while in the hospital. And I will come back to them. And then the breastfeeding of the baby while at the hospital. And visiting by parents who are COVID-19 positive to see the babies after discharge of the mother and even the father who becomes a PUI, even if he has no symptoms, cannot come and visit the baby. And then how do we do it? I mean, we just now do with some videos and stuff, but that is a challenge. And then how do we discharge the baby home, especially a term baby? Do we do it a non-COVID-19 caretaker? Or what if there is nobody with both mother and father have positivity or symptoms? And then the last one is the allocation of resources to the pregnant women and particularly the extremely premature infant.
Can I raise a couple of questions on the left?
Yes.
Well, one question came from one of our participants wanting to know clinically, do you recommend checking asymptomatic children if the parents are positive for COVID-19?
Yeah, this is a very good question. I mean, the challenge is in terms of, if you ask me personally as a pediatrician, I would say yes, but also there is a challenge, in terms of availability of testing materials and location, and taking the child to the location to get it done, especially to an emergency room if that is the location. And so usually at this point as pediatrician, we recommend even if the mother or father has a COVID positive status, to practice all the physical distancing as much as possible with the child is not easy, but at least do all the washing, masking, and taking care until they show any symptoms, unless we have enormous testing materials become available. These are the challenging questions. And so the separation of the mom and the significant other during the delivery happens because of the fear of exposure to the healthcare workers. And even though it does diminish the autonomy of the parents to be at the time of the delivery, and this is currently the recommendation of the hospitals, unless there is a different way of being able to bring them together. The way the hospitals are structured, it's very difficult at this stage. Even more challenging is the separation of the mom and the baby after delivery has very limited or no evidence for that separation. It was started in China that they separate those babies and mothers, and it has been continued with the theoretical risk of spread to the baby. And I just want to mention a couple of things as to how the babies get the protection. It is either the mother is vaccinated, if vaccine is available, she produces the antibodies and then passes to the baby through the placenta, or the mother gets infected, produces antibody that passes passively the immunization to the baby. And otherwise, it is the breastfeeding. If the mother is COVID positive, she is producing antibodies that we know of so far, and she will pass it in the breast milk. That gives protection to the newborn. And the breastfeed milk itself has been tested, does not contain the virus so far. And so this is the best method by which the baby gets it. So the separation of the baby in the hospital does not make sense. The baby and the mother if the baby is not sick, should be with the mother and with all the precautions. Currently, the American Academy of Pediatrics recommends to consider separating the mother and neonate. And whereas the European documents does not recommend to separate mother and the baby, except in a very limited situation. The Brazilian Pediatric Society also does not recommend separation. The guidance by WHO also just came up on April 28th, that they should be enabled to remain together and practice skin-to-skin contact, kangaroo mother care, and practice rooming in throughout the day and night, especially immediately after birth during establishment of breastfeeding, which long-term is much more important for the baby. And especially since we know so far, the infants do not seem to have significant disease at this point. This is something that applying this evidence currently, I consider there is no basis for separation, but it is practiced in the hospitals because that is the American Academy of Pediatric recommendation. And if you look at in terms of as long as the mother puts the mask on, washes the hand before and after, and the breast and keeps the baby at a distance in between. The alternate way is to express the breast milk and feed, but it is still not the best in terms of establishing breastfeeding early. Ethically, the principles of beneficence, the best interest of the baby and the mother, and the bonding, and non-maleficence, not causing harm. Even though non-maleficence is what is applied in separation, it can be also applied. And also the autonomy of the model agent, the mom and the father and the baby, should come into play. And we actually, from Georgetown, we have written to the experts in AAP, and hopefully the recommendation to separate will change. The next two issues that I want to bring up, hopefully there is time: visiting by parents who are COVID positive or PUI. It is a challenge because the parents to come in to your NICU, it potentially can expose the other babies that are in that place. And so in terms of for the benefiting the common good, that they are exempted from visiting. We use tablets and iPhones to show the babies to the parents on a regular basis through all the social media. At least the technology makes it possible. And unfortunately, the hospitals were built not with the pandemic in mind. So there is no separate entrance for these parents to come to separately to your room, where the patients, parents, babies are staying, so they can come and stay with the babies. And so it is not possible. That separation is what is being recommended. The other problem is the discharging the baby is another challenge, because if the mom is positive, the father is a PUI or maybe positive, and they have to take care of the baby unless there is another care provider available, which is not readily available for everybody. There are some families where they may have, but unfortunately the grandmother or grandfather may not be the right person, even though they are negative, because they are at higher risk. So we don't want to expose them either. So they have to go with the mom. That means we have to give a lot of detailed instructions to the mom, and at the time of her discharge, and then at the baby's discharge, reinforce it. But it would have been good if they can come and do this. Last point, if there is time, I would like to mention about the allocation of resources. I'm just going to address for the extremely premature infant. In fact, there was a new article has just been published 2 days ago in American Journal of Bioethics. And I'm quoting from there because the neonatal units have ventilators. Some of these ventilators can be adapted for adults. And this raises the question whether in crisis conditions, which you all heard about where this conventional to contingency to crisis we go, during these crisis conditions, the guidelines for treating extremely premature babies, some people suggest should be altered to free up the ventilators. And some adults who need the ventilators may have a higher survival rate than some of the extremely premature infants. And so they should be given up. But the surviving babies will likely live longer, maximizing life years. The empiric evidence demonstrates that the babies can derive significant survival benefits from ventilation when compared to adults. And so when triaging or choosing between patients, justice demands, fair, and equity in the guidelines. Premature babies do not deserve extra special consideration. They deserve equal consideration, and that's something to keep that in mind. And there are now prognostic information that is available from NIH as well as from individual institutions of survival of how low a premature baby can. Of course, solidarity is crucial, but we also must consider needs for specific to patient population and avoid biases against people with disabilities and extremely premature babies. So let me stop there, and I just want to reiterate what Alan and Sarah also said. Dan also mentioned principles and values that we laid out in the early part of this presentation holds good for pregnant women and neonates and children, even during this pandemic. evidence-based decision is also ethical, and if applied fairly and equally across the spectrum of ages, and not old age or young age, gender, race, and not change the ethical principles and values just because there is a pandemic. Thank you so much. And I also thank Annenberg Nutritional Center and Dr. Paolo Manzoni and Dr. Dan Sulmesi for sharing some of the slides. Thank you.
Thank you. Can I follow up on two questions? One is, when we're talking about the crisis standard of care, triage care, especially if we were to enter into that time period where we have a shortage of ventilators, and you know, I think your point is well made about, you know, premature infants having an equal consideration, not necessarily a special one. Some protocols across the country do see give pregnant women priority in terms of ventilators. Do you have any thoughts on that?
Run that by me again.
Some of the triage protocols across the country would, in terms of their scoring systems, would give some preference to pregnant women.
Right.
Likely near viability. You know, what would equal consideration look like under a triage protocol for a pregnant woman and allocation of resources?
I think, you know, we are very good, you know, in terms of intensive care units. Let us say a pregnant woman gets admitted. You know, in fact, we have, you know, and you know, the look in terms of what is the diagnosis, prognosis of that woman, and at what gestational age, you know, that woman is there. So those are the considerations that you need to give the same as the other. And so it is not like that you are giving extra because there is a fetus in there alone, but also because in terms of what is her disease. Yes, we have, not just in pandemic COVID, in other serious diseases where pregnant women get into serious illness, and let us say at 24 weeks of pregnancy, the baby can still be delivered if that is necessary prior to making the decision in terms of the mother, whether you continue or not continue due to prognosis of that patient. So that, I think, is something that we should keep that in mind.
Okay. And one of the participants in the webinar wanted to know what your biggest concerns are related to separating mothers and babies.
Yeah, I think this is where I like the WHO recommendation. I think the recommendation is that in terms of that the early time are very critical for establishing breastfeeding. And so they need to be present. It's not that impossible that if they have not done it later on. We have done it even after 2 weeks, 4 weeks, we have been able to reestablish breastfeeding in moms. But it is very critical that early part. The second is, this is a time of significant mental anguish for the mother. The bonding needs to happen with the baby being there. And that actually provides help and stimulates potential healing, you know, endorphins and others that could also help the mother, you know, in terms of facing the disease that she is actually is there. And then the third, there is a long-term implication for the fetus, for in terms of growth and development with the breast milk feeding and the breastfeeding. And so that's why I'm a very, very strong proponent and push it very hard, you know, in terms of how to make sure it is established. We try so many different ways we try to do it. And so that's why, you know, we are so specific about that.
Thank you. Thank you very much for your time today. I appreciate that.
My pleasure.
In concluding our session for today, I'd like to invite you to next week's seminar on May 7th, which will be on the theme of moral distress. And as we move into May, we're going to be doing only 30-minute segments instead of 2 30-minute segments. So we have all of the sessions will be posted on the Catholic Health Association website. And the other thing I would like to mention in closing, because this comes up pretty much on all of these podcasts, as long as you are registered for the sessions, you will be getting an email once we are able to post the recording saying that that's available. And we also provide a PDF of the slides that the presenters gave. So those will be also linked in the email from Catholic Health Association. So thank you very much for attending, and we appreciate your presence.
And on behalf of the Catholic Health Association and Georgetown University, I'd like to thank you for participating in today's event. A recording will be sent in an email and will also be posted on CHA's website at www.chausa.org/coronavirus, where you can also find recordings of parts 1 and 2 in this series. This concludes today's program. Thank you for joining us, and have a wonderful day.